You're listening to the Beyond Nurse Residency podcast, an educational series where we interview experts on all topics related to the transition of new graduate nurses into practice and beyond. I'm your host, Nicole Weathers, director of the Iowa Online Nurse Residency Program. Thanks for joining us. Let's jump in. I've been thinking back to a time early in my career when I was training to a new specialty area, obstetrics. I did everything I was supposed to, right? I went to the classes, I attended the conferences, I checked all the boxes on my competency checklist, spent hours working with a preceptor. And then, like many of us, there was that day where I became sort of on my own, working independently. And here's the truth. Like, even though I had all this preparation, I didn't really feel competent. I could recite the material, I knew the steps, but in the real world with real patients, with real pressure, I just never really felt like I had mastery. I tried very uncomfortably for a while, and then eventually I realized this just wasn't for me. I wasn't meant to be a labor and delivery OB nurse. So, really looking back at that experience has led me to think more about competency and that it's not just sort of this clinical requirement, but there's a lot more to it. And so today we're going to be shifting our conversation into this idea of competency, what it means, why it matters, what it influences beyond maybe the obvious, and how leaders can maybe simplify that competency process in a way that helps nurses thrive instead of overwhelm them. And to explore all of this today, I'm joined by Donna Wright, someone whose work has shaped the way many organizations kind of think about competency. So welcome, Donna. I'm so excited to have you here with us today.
Thank you, Nicole. Great to be here. Love to talk about competency anytime.
Well, and I don't even think you know this, but I learned about your work very early on. So I was an educator at a small rural hospital. I was charged with onboarding, orientation. I was trying to figure out the competency thing, and I bought The Ultimate Guide to Competency Assessment, and I had great thoughts and ideas of like, this is what I think we need. This is so great. Unfortunately, at the time, I ran into some roadblocks with getting the other people in my organization on board. So maybe we'll talk a lot about that today as well. But I've actually been following your work for a really long time. And again, even though we haven't maybe formally met, I'm so excited that you're here and you're joining us for this conversation. So why don't we start off by having you introduce yourself to the rest of our audience?
Okay, well, thanks, Nicole, and I'm glad I'm here joining you in this discussion. My name is Donna Wright. I guess I would call myself the competency lady. I'll give myself my own title, but I'm actually officially a consultant with Creative Healthcare Management, which is an international consulting firm that does all kinds of things, helping people prepare for Magnet or developing their leaders or looking at their competency processes and programs or looking at relationship-based care. We do all kinds of different things. So that's the group that I'm a part of. And however, I have been studying competency assessment for 3 decades. It is a passion of mine. Kind of a sick career choice, but I love it. So I've been speaking, writing, reading, talking about competency most of my professional career, and happy to be able to spread that through different means. So I've written several books. I do a lot of different presentations and conferences. So yeah, anytime I can talk about it, I want to do that.
Excellent. Well, and it sounds like you're more than the competency lady. It sounds like you're the competency queen if you've been doing this for not long.
Okay, I don't know. I don't have a scepter, but
Awesome. Well, again, really excited to dive into this conversation around competency. And before we do, or kind of to start us off, I think it's always good to just make sure we're all talking about the same thing. So kind of level the playing field, do some groundwork here. So when we talk about competency in nursing, what does that really mean? Why don't we just start there?
Okay, sure. Yeah, I think a couple different things. First of all, it's much more complex than we realize. And we want to make sure that people are competent. Well, what does that mean? Well, I say there's many different levels or phases that we assess this at. So, I'm a nurse, you're a nurse, and this could be for any professional group at all. But you first start out by preparing yourself in your profession, which is the professional preparation, going to college, and then passing an exam and getting licensed or certified or registered. So everybody does that kind of thing. That's the first level of competence. Then the second level is really where you're coming into an organization. And the question is, how do you then express that licensure, registration, or certification in our area, our organization? And that's where people right away kind of get messed up on things. Sometimes people want to redo the exams we took, like the NCLEX exam. We're not here to recheck that. But then there's always the question, well, what if they didn't know how to do that? Or, so there's this apprehension. And that's why we still have to kind of watch that. But we have so much stuff in our orientation checklist, so to speak, that get into checking off the basic head to toe assessment again. Really? No. So what you're really trying to do is that if you're getting a job in an organization in the middle of rural Wyoming, or you're going to work in downtown Manhattan, New York, these are different places and you need to express your talents in different ways. Are you going to be working in an independent clinic where you're the only nurse or other professional available? Or are you going to be part of a large team that's doing different things together and you're sharing the work? So it is about expression of your skill set into a specific location. And that's where I think we mess up. We right away slide right back into, are they just a competent nurse who left college, or competent professional? It could be a pharmacist or a physical therapist or whatever. And then we're checking that off again. And that doesn't serve us well. And like you said, it didn't help you fit in to what you needed to do in that clinical area that you didn't feel comfortable in.
Why do you think that is? Like, why do you think we slip into that? Well, we're just going to check the box and we're going to check them off things that they should already know. Why do we go back down that path?
Okay, we could do a whole 8-hour workshop on this one. I'll tell you in brief. It comes down to some trust issues. It comes into all kinds of different levels of trust. And this could be even beyond just the orientation. Let's also get into the ongoing competency stuff as well, too. But it's like, how do I know that they're like this? And as an executive, how can I see that? How do I know as a preceptor that they're going to be good at this? Or as an educator, how do I trust that the nursing school they went to covered that, or the other preparation area that they went to made sure that they had that experience? So I have to say, it's not about like you're not a trustworthy person, but our systems aren't really built to build that trust. And I've worked really hard to figure out ways we can do that so we can trust people. And that actually loops right back to engagement. If you want to talk about engagement today, that is one of the best things, where when we have that systematic, the trusting kind of things in the system, then you start to eliminate some other problems as well. So we'll just keep circling back around to that in this conversation today, that it's trust, and it's not trust in a way you always think that they're not a trustworthy person. So it's different than that.
And I sometimes wonder too, so I could totally see it being trust. I also see, checking the box as sort of the comfortable, or, I mean, no offense to anybody who does this, but kind of the easy way out.
Mm-hmm. Yep. And that leads to a second component too. There's a fear-driven component that enters into competency. I have fear of the regulatory bodies not approving us. I have fear of being sued as an organization. I have fear that someone's going to accuse us of not preparing people well enough, and then we have a situation with a union or something like that. So we have a lot of trust issues, a lot of fear-driven things. These are really across the board for a lot of other things in any organization that stop us from being truly successful and truly engaged and truly leveraging the talents of everybody. These are some just core principles that, boil down to the culture in which we create within our organizations.
So as much as I am all about like, what do we need to learn about competency to make this better? I think sometimes the question too, we need to kind of approach it a little bit different, but like, are there things leaders, NPD need to unlearn about competency in order to effectively move forward?
Yeah, I think, well, actually, the word you just used is the word learn. I think some people right away think competency is all about education or it's about learning, which is actually the second step. Don't get me wrong, it's right in there, but it's not the first step. Actually, when we think about stuff around competency, it's more about what do we need to be able to have or do in our job or as an organization, and do we have the people to be able to do that? For example, one time I saw this beautiful definition one time of competency. Actually, I think it was in one of the Joint Commission manuals years ago. It was great. And it said, competency is all about requirement equals capacity. And what they described was what you're required to do or what your organization says they're going to do. What's your requirement? Do you have the people or the capacity to fulfill on that promise? So let's say you say we're going to be a level 3 trauma center in our organization. Do you have the people who know what a level 3 trauma center looks like or can do the skill in that category? If you say you're going to be a PEDS friendly environment in your hospital, your organization, do you know what the components are? Or can you express PEDS friendly environment in your practice? And so that to me starts to change everything where it's not about me, the individual, learning something. It's about me saying, I'm in this organization. And if we've now been designated as a stroke center, do we have the people who have the capacity to deliver on that, to do what we say we're going to do for the public? So it just changes the entire thing. It's more about what's required in the job. And now this is what's exciting as leaders. That's really articulation of expectations. We haven't even got to competency yet. That's what do we expect of you in your role?
That's a really interesting way to, I think, look at it, because I think another thing that we sometimes see, especially with new graduate nurses, is, this new nurse is brought in to fill a role that maybe a 40-year nursing veteran has exited. And we expect them to be at the same level.
Yep. And that's true for just about everything we do, whether it be, and this is where I'll say I put competency in different categories. So, you want to be able to do things that determine should someone even come into your organization to be hired. And then what do you do during initial competencies, which is the orientation plus getting them grounded into the experience they're going to be doing. So it's more than orientation. That's why I use the term initial competency assessment. And then after that, the ongoing competency assessment has to be a part of it. And actually, that's the strongest factor that cements the DNA of your organization. I love when people say, I've been here for 20 years. Don't you know I'm competent by now? And I say, if you're still functioning like you did 20 years ago, you ain't competent. You have to constantly keep evolving. It's that commitment to, I'm always going to strive and move forward with my organization. And that's the partnership we have. And it's not about now I'm competent. No one ever is truly competent. It's always it's a dynamic process. So that continuum, that flow, that commitment to moving in the direction where we've designated we're going to go, then it's a collaboration after that of the employee and the organization moving together.
So this may be a silly question. I don't know. But do you think about competency as like a one size, fits all? Like all of my nurses on my unit are being held to the same level of competency or requirements?
Yes and no. I'm going to say is it one size fits all. I believe the expectation is the same. How we're going to express it can be different. So first of all, and it doesn't mean that we're all at the same level. I want to be clear on that. But competency needs to describe the minimum expectation you need in an area. For example, if I'm in the ICU, the minimum expectation we have for responding in a code is ACLS. That's pretty high. That might be on Benner's model way up to proficient as far as skills go. But everyone in the ICU needs to be at ACLS or higher. Some people have passed the ACLS requirements. Some people are teaching it in the ICU, so you can have that level or higher. It's okay. Or where another clinical area might be BLS and that or higher. So you have to describe the minimum expectation that everybody in the job category needs to have. So minimally, you need to be here. And then you even define it as people come into the organization. I'm not expecting them to function like that 40-year nurse that you talked about or a professional. But I expect them to be able to get up to this minimum expectation so they can take this basic assignment or do this project or do this work, whatever we're asking them in that role. So competency is about you need to be here or higher. Then how you can verify that's where it gets creative. Oh my gosh. That's the part where we can individualize it and allow for different personality types, learning styles, engagement things. So during the initial competency period, I tend to give fewer options just because Most people coming in are not looking for a lot of freedom yet. They want to just tell me what I need to do, and they're focused. And that we just need to know that. That's where people are then. But I usually like to have an option that would be good for a new grad and someone who's seasoned. So I almost always like to have two options. Don't make a seasoned person go through everything that the new person, like, I know this. I've been an oncology nurse for years. Can I just take a test to prove I know, or can I show you my a certification in oncology, or whatever. So you have to have like maybe two paths for initial for verification, but or two or more. And for the ongoing, I like to give, two, three, four, sometimes even five choices where people could bring different things that say, prove that you know how to do this, or you can take care of this type of patient, this new ventilator patient we have, and maybe we have different verification methods that can be done on different shifts and with different personality styles to it, or things that could be caught during a QI monitor that you already got caught doing it correctly because you're doing it all the time and you're engaged with it all the time. Or some other people do a case study because they don't know where to even begin, and they can read about it and do the case study or the module. So, yeah, it's kind of all the same for the competency, but the verification is where you start to get creative and have options.
I wrote down this word realistic. So I like that because I mean, that is something that we've talked a lot about with a lot of our partner organizations is we need to just make sure we have realistic expectations for each unique sort of individual that's coming into the organization or each sort of level. So new grad expectations, while we still hold them to the same minimum, we just need to be realistic in those expectations for them.
Mhm. Yep. Yeah, and I think that's where, especially during orientation, I lean into the tiered orientation process. There's a lot of different tiered models out there. But in general, what tiered says is that you kind of are on a path somewhere and you designate within that tier. And just so if people have never heard of the term tiered orientation, it's kind of like saying first you need to crawl, then you need to walk, then you need to run. That's kind of the basic way I describe it. So in orientation, you're describing for people the whole process you go through, but you might graduate from orientation, so to speak. I just use that term to say with just the walking part. We don't expect you to run yet. I want you to not only know it but can apply it at least once. Or I need you to be able to do the whole thing because you're in charge and it has to go all the way up to the running phase. So each competency can have different expectations, but you're defining that. And then that puts a map for later too. So I'll go back to the ICU, and you need to be able to complete ACLS and prove that you can function in a code. But in a year and a half from now, we expect you to be a code leader and do the debriefings. You see how I just took a new grad and helped define the path they're going to take in the ICU. They're going to get to a higher level, but not during orientation. Just function in a code, please. That's what we want to get you good at.
Right. And I think that's a mistake maybe a lot of organizations make is that they're not always realistic in their expectations for new grads as they come in. They're seeing that, a nurse is a nurse is a nurse, regardless. And so, I guess just as you're kind of talking about that, that's something that's kind of like percolating in my brain here about how this might be an area where we need to begin to really work with organizations to kind of rethink how they do this.
Yeah. And our systems don't necessarily support it very well either. So I think sometimes it's not just let's change some competencies. We need to change some of our systems too that support it. Because I think educators feel panicked that I have to get everything into orientation. Well, no, that again is not realistic. Exactly what you said there. Or how can we do this so that we have this pathway or plan, or you're creating a portfolio for yourself, and yeah, there's all kinds of different ways you can do this to make it better. And actually, these things end up saving money and time in the end, too. So this isn't, I don't know. We just have to rethink how we do our systematic processes.
Because I remember being a, educator in a hospital and, we want to get this orientation checklist done by the end of your preceptor time, right? And totally not realistic, especially in a rural hospital where we might see a chest tube once a year. Like it's not going to happen in the, 6 to 8 weeks or whatever we were giving them at the time to get that done. And so I like this idea of it doesn't all have to be covered in the beginning. Like, again, figuring out what that minimum is kind of working towards that standard, but then giving them space to grow. So I think that's just a great way to kind of look at competency.
And I don't know if we are always so good at even articulating what we expect, even for ourselves. We hear all the time, hit the ground running after orientation. I want them to hit the ground running. What does that look like? And, we need to be clearer about that so we can help them understand. We expect you to look like this at this point and then like that later on. And we completely miss certain things that they desperately need. Like during orientation, people need to feel like they belong to the group. And they get a connection with a preceptor. We hope sometimes it doesn't happen, but the whole group and building trust with the whole group. We need to help them with just even how to do days and nights and evenings and how to, manage home life and here and park your car somewhere. I mean, we tell them stuff, but we don't always help them truly manage that and embed that into who they are. Some of our well-being stuff and professional parameters of wellness around what we do and how to do that every day. There's so many things that I am now redoing in orientation. So we're moving from that checklist of head to toe assessment to something that's much more professional driven. And I want to see the verification that the employee has back more of professional curiosity, of understanding how to engage in communication with somebody outside your department. Get a hold of a doctor that's hard to get a hold of, things like that. The things that we know are really the secrets of the job.
Well, and I think that's something that, is always kind of a topic of conversation around residency and new grads is we have the clinical sort of hands-on technical skills, and then it's like everything else. And it seems like people are much more concerned with the hands-on clinical type skills than the everything else. And so I guess what's your thinking around that? Are some of these competencies more important than others? Do we, look at these competencies differently? Maybe you can talk a little bit about that.
Yeah, I think where we're at right now is we often divide up our roles, however we define it, into a list of tasks. And we've all felt that way for a long time. And we check off all these tasks. It could be protocols or procedures people have to do, or we look at their charting, or we have them take a test of knowledge, things like that. And I feel like sometimes in orientation, it's like we're telling the new person, um, we're going to give you a new car for orientation. And it's here in these boxes, and you have to put it together yourself. So the parts are all there. Don't get me wrong. Somewhere in these boxes is a Lamborghini, but you got to put it together yourself. And this is where I hear so many times people say, they'll ask the team, how's that new person doing? And the team will respond, well, they were checked off for everything, but they still don't really get their job. So what are we missing in that? And I think we haven't made it, we've taken the test and we haven't made it comprehensive. So I'll give you an example that I think can actually deal with some of the trust issues and the fear issues, the belonging, all that kind of stuff, and the skill set at the same time that we need to check off. So I've got several groups now that are saying during orientation, you get like a list of 5 or 7 essences of the job. Like you find the job in this area, kind of these are the essence of who we are. And so we say, while you're caring for a patient with your educator and or preceptors as you're going along, you need to, at some point along the way, contact a doctor, get a hold of them and have them call you back and maybe change an order or something like that. You have to set up some communication with another department. You have to discuss some things with the family or do some teaching with the family or look at something with the family. You need to adjust the care plan. These are different things, not all with the same patient, but with different people along the way. And then you put together kind of a case presentation with these 5 to 7 different components that you have. And you can use 1 patient or 2 patients in your case study if you have to, go to more than one to get your story that you're going to put together or your couple stories. And then at the end of orientation, once your preceptor says, okay, we've checked everything off on your list, I think you're ready to present your story to the team. So then you go back to like a staff meeting or something where the whole team is there. And you say, the preceptor says, I'd like to introduce, a new person. Many of you have worked with this new person, but they're just about ready to finish orientation. And why don't you share your case study? And then they go, okay, here's where I called, Dr. So-and-so and blah, blah, blah. And I helped with this. And then I have to adjust that. And I did that to help the family. And here's my presentation. And people like, wow, awesome work. You were able to get a hold of that doctor. He's so hard to get a hold of. And you set up a thing with physical therapy. Good for you. So I, as a staff person, now start to see you as someone who I met maybe, a month or so ago, 2 months ago. And now I see, wow, look at the progress you've made. I feel much more welcoming to bring you into our team, and I feel comfortable with you. You have shown how you can put the whole picture together and do the entire kind of job, and you're bragging it up, and your preceptor's right there to make sure that you don't falter. And I think that starts to put everything together. And what if we got rid of the checklist? We just used that as a tour guide, and we said, you have to have your team endorse that you're ready to go. And right there, it would change everything.
Wow. That is a very interesting, I think, approach to this. It sounds really, it makes a whole lot of sense, right? That is kind of, that's the ultimate goal. That's the outcome that we're really after, is to have nurses that are working on our units that can do those sorts of things. But we segment everything out and we break everything down and we do everything sort of in isolation. And I think that, thinking back to the example I gave at the introduction to this episode of I was able to do all of these things. I could recite this information. It was harder for me to put all of these OB skills, together. And it makes me just wonder, if we had taken a different approach, would that outcome have been different?
Yeah. Yeah. And I think, and along the way too, I think it helps people to see if they're in the right specialty, because maybe you weren't, maybe you were, I don't know. But also to say, in that OB position where you know, did you see the complexity of family dynamics and GYN, OBGYN is complicated sometimes, and that some people thrive on that, how to help that, bring that new person into the world, but in a situation that is not always easy. And I see that, how can we help people embrace that in a different way? I just think what I just described to you was a lot of changing systems, but it doesn't take a lot of radical stuff to do that. It just takes some purposeful action to say, are we ready to move from a checklist that has not served us well over the years? And we know that, to something that maybe even ticks off more of the boxes of a broader scope, a more comprehensive way to look at our role than just the skills or protocols or procedures we have to do.
So this might be pretty obvious, but so much of I know so much of our discussions and our nursing professional development groups at the national level at ANPD, there's so much discussion around competency beyond sort of the regulatory aspect of competency. Why is this such an important topic for us?
Well, I think twofold. One is we're back again to the trust and things to make sure that we have the people. Because to be honest with you, when it comes to being sued or dinged by some survey group, they hold the organization accountable. So the organization just goes right into it. Even in a lawsuit, very rarely does a professional get sued. It's more, unless it's a doctor, but it's more the organization. And the whole key to the lawsuit is, did you make sure that they were competent? That's really what the lawyers are going after. So it isn't, so much the individual, it's the organization, that they have systems in place for that. So that's one part of it. And then the other part is that the world is changing just so fast. I will tell you that, and this is more than just post-pandemic, but the half-life of information from the 1980s to now, in just 40 years, has just exponentially grown. From 1980s, it was about 2 years, that the half-life of information. The year 2000, it was right around 12 hours. And now we're in the decade of the 2020s. We're talking nanoseconds. And so this ongoing, always, I have to always be more and more current and know more things. And, within just in moments, it changes. Everybody that's listening here has probably had a protocol last year that came out at the beginning of the year. Then a month later, it was tweaked and changed, and now we're going to do this. Oh, but now you can't dispose of that like that. So 3 weeks later, a new thing on how you dispose of the stuff, that the IV things that you pull down, and then you have to label it like this. There have been 5 changes in a protocol all in 1 year. So are you competent? well, where are you competent? If I ask somebody, are you competently doing it? Well, yeah, no, you're not because you didn't dispose of it correctly. You didn't document it right. This has changed. That has changed. So, right there, we're in a different world. So, I think that's why it's so important now we get good at it. Yeah.
Mhm. Do you think that contributes to some of like the burnout and things that we see in our nursing workforce is kind of this half-life of information and the constant change and the constant need to, you know, look at competency?
It could be. I could be, but I think for me, and this is just my opinion, but I think it's helping people find the passion of their work. I really want people to, there's a reason I want to have curiosity with this. There's a reason people went into the profession that they did, and frankly, I bet you and I probably have this as well too. Didn't you have some things that you imagined in your head you'd do as a nurse? That I thought I would sit with a dying patient holding their hand. What was not part of that picture was somebody screaming from the hallway, "Hey, Doctor So and so's on line 4. You wanna come and talk to" it's like, "Just a minute," like, I to find those passions and then help people get those moments in the reality-based world we live in. I know that sometimes that wasn't always realistic, but I have now found as a nurse, some of the things that are the most difficult to do are the things that bring me the most joy. It's having that crucial conversation with a coworker and really finding common ground and finding out we have a lot more in common than we have differences. Oh my gosh, I can work with that. And that's awesome. Using therapeutic relationship within our teams. Oh, I love that kind of stuff. So I don't know. I think it's not so much I think I don't want to get into you got to work smarter, not harder. Like we just got to go faster. I think it's different because I don't think people get into healthcare because they knew it was going to be easy. They got in because it was going to be a challenge, but let's find the joy in the challenge or the passion. And that's what keeps my fire going. I don't know. How do you feel about that, Nicole? I mean, where did you get your passion? Because you've been in this a long time too. So,
Yeah, I mean, I think well, my next follow-up question to that was going to be like, how does competency factor into helping you find that passion? Does it?
yeah. Okay. Yeah, probably. Well, and I think even helping people find the right specialty. I think when you come out of your preparation school, your professional preparation, you don't know what you want to do. You might think you do. I mean, I have so many people, I want to work in peds. And I go, are you sure?
Yeah.
Because that's hard.
Or labor and delivery,
Yeah.
right?
Oh,
Like
with
everybody.
babies. It's hard. Yeah, you have your first stillbirth, and oh my gosh, this is a difficult place to be. So, I just say, and I will tell you, my specialty that I found was my true love. I did not know it even existed in nursing school. And I'm a head and neck cancer nurse with laryngectomies and trachs. And if someone along the way, a preceptor and educator, didn't help me understand that my ability to, well, move into some surgical services with airway management and things like that, if they didn't help lift that up for me, I would have never thought head and neck cancer is my love. It's sputums and trachs. Who wants that? Oh, but I thrived in that specialty. So I'm grateful, and maybe we have to have systems that not only allow the person to know what they want, but the preceptors and educators to have things in place that help support, um, matching the person with the right situation. Um,
Mhm. Yeah, I mean, because I would say, I initially thought I wanted to be a science teacher. I loved sort of, biology and some of those things. I ended up down the nursing path and, anytime like patient education. And then I was introduced to this world of nursing professional development and it was like, oh, wow, I didn't even know that this was an avenue that my career could really go down. So, yeah, I do think a lot of the things that you're exposed to, and then even, when you first start in a profession, like let's say, education, practice-based education, you're kind of interested in it at first, and then you find out like, oh, there are a whole set of, competencies and practice models and all of these things that help me do my job better. And then with that, I think passion kind of continues to develop and you continue to grow down this space. So I could see, it's obviously a combination of a lot of different things, but it does feel a little bit like competency in an area, does play a factor there for sure.
Yeah, and I can just share my own personal journey that early in my nursing career, I thought I wanted to work in the operating room, which I did try. I will tell you, it was not a good fit for me, but I didn't realize. I mean, here's where I started. I thought, oh, I love surgical stuff. This is going to be great. But what I didn't plan on in the operating room, especially in the scrub position, you're next to the doctor. You can't move around. You got the mask over your face. And some of people know who I am. I'm very expressive with my whole body and my face and everything. I'm a very outgoing person. I would bump the table. I would hit, and then they would complain on, oh, she's too fidgety and all that. Finally, my manager and the lead preceptor sat me down and they said, this isn't probably the place for you because here's this, they told me gave me some good feedback. And I was so devastated. Oh my God, I'm not a good nurse. They said, oh my gosh, no, you're a great circulator. You're moving around, work in the room, and you have high energy. We know where you should go. And they recommended to me that I should go to PACU because I know all the surgical procedures and I'd be great to wake up the patients. Woohoo! You need Donna to be in your recovery room, which then led me to airway management, which then led me to head and neck cancer. So you see how, and I'm not saying we have to be a career counselor for people, but I am so grateful that people early in my career saw what worked for my personality and what didn't. And it got me into the right place. And I don't know even how they did it back then. I wish I kind of could see, did they map out, is she a safe enough nurse, but surgery's just not her place? I don't know. So I'm trying to, bring that to life in professional development of how can I help people be able to look at that.
Well, and I love the sort of that strength-based approach, right? It wasn't like, here's where your weaknesses are and we have to fix those. But instead, let's look at, what strengths you bring to the table and how we can really use those to help you down that path towards, what you might find passion in.
That's a great way to put it. Yeah, that strength assessment versus gap analysis of where you're falling short.
Because
Yeah.
we could have spent all the time in the world trying to get you to be the person we wanted you to be in surgery, right? But instead, we helped you find kind of where you could go.
Yeah, exactly. You're right. And I don't think I would have loved it there. I mean, I go there now and I look at it and I say, yeah, that's not my personality at all. But that's okay. It fits for other people. That's fine.
Yeah, for sure. So this year we've been talking a lot about sort of nurse engagement and the things that influence nurse engagement. And so I'm just curious if you see any sort of connection between competency and ensuring our staff have competency, in these, certain areas, depending on our specialty, and the level at which they become sort of engaged in their work.
Well, first of all, I'm going to say this from a couple different points where engagement really shines. I'm going to actually start with the ongoing competency process where once you're in an organization, when you can start to be part of the assessment of what do we need for our to be successful in our job. If our job is expecting us to do this, what competencies do we need where we actually get to own our practice, our service, and our competencies? It starts to change everything. I see a direct link. People are reporting time and time again when we made we had the team be able to identify their own competencies as a group with their manager and their educator. I'm not saying they do it on their own. We come together and say, what's happening in our cardiac unit or our behavioral health area, whatever. And you say, this is really what we need in order to achieve the goals that our organization has set for us. So it's a beautiful gap analysis that we can then pick our own competencies. Shared governance gets stronger. Staff satisfaction goes up. Patient outcomes get better. And you have a longer retention of people, the people you want to keep. Those are all things that just excite me. So you want to have people engaged in that so they can own their practice, their work, and their service, and therefore their competencies. So that's a part of it. And so that's one aspect of it. The other part is when we're looking at engagement, giving people choices and options with their verification means everything. And if you can make the competency verification methods matter and the competencies matter, then people just start to shine. I can share another example. I was recently in an OR. I mean, this is now for my consulting job. I was working with an OR team, and we were going to go into the surgery area, and they were going to show me some different things. So I'm changing into scrubs, and I'm with another nurse that I've known for years. And she opened up her locker, and I saw in her locker a verification method. It was actually an exemplar, a story that she had done a reflective thing on, and it was 3 years old. I recognized the form, and I said, you have that form still? And she said, oh, yeah. I said, you don't have to keep it. We've uploaded that in the computer. You've been checked off for your competency. You don't have to keep it anymore. And she said, I will never throw it away. She said that exemplar that I did was one of the best things, the best moments of my professional career. It was a difficult day where I had to stand the ground and be an advocate for the patient in the operating room. And I reflected on that moment and I wrote my story down. It is like a thank you note I wrote to myself. I went, oh my gosh, when somebody is keeping a competency verification method as a souvenir, oh my gosh. But she was so proud of herself in a moment where no one really saw her do that, but she got credit for it through the competency process. I just love stuff like that.
Well, and we're terrible about taking that. I mean, we're working our shifts, we're getting to the next patient, we're rushing, rushing, rushing. Rarely do we take the time as nurses to sit down and probably reflect on some of those things.
Yeah, and imagine if we had a competency that said, something about being an advocate in a difficult moment or dealing with a difficult situation with a professional colleague or whatever the competency is. This is where we can get into some competencies other than skill, like the kind of technical skills. We're getting into critical thinking or interpersonal skills and stuff like that. And she chose to do a reflective story on that, which then her peers reviewed and all of that. So it was truly competency verification. But it was something that after it was all done, she kept it. And I go, wow, that's absolutely what we want to do. We have to have competencies that matter, where people say, this is why I got into this profession. This is why I do what I do every day.
And I think sometimes when it doesn't feel like it matters, like when it feels like we're just checking the box, nurses are less likely to probably I don't want to use the term engage over and over again, but they're less likely to really put time and effort into it because they feel like it doesn't matter.
Well, and we can use the word disengage or being disenfranchised. Here's a very common thing that happens in almost every organization I go to. Somewhere we have, we got a problem with something like, oh, we have a problem with CAUTI, catheter-associated urinary tract infections or something like that. 80% of our clinical areas are having a problem with it. We're going to make a mandatory competency this year on CAUTI. Everyone has to do the module and test. So we do this. This is what's called spray and pray. We spray it on everybody and pray that it's going to improve outcome. So now imagine if you and your team are not part of the 80%, you're part of the 20%. You guys have been working hard to bring your CAUTI rates down. For 2 years, we've had 0 CAUTIs. And now you got to do the module and test on CAUTI. You start to say, why do we even bother? Doesn't anybody see how great we are and the work we've done? So you don't just keep that group average. You actually suck some life out of them. And that's the sad part about the approaches we take with competency, is that we've actually kind of not increased engagement, not even increased competence. We kind of made people say, who cares anymore? Just do what you're told. That's a sad place to be.
So what I hear you saying is not only is maybe competency, important for engagement, but how we are validating competency is going to be important for engagement as well.
Absolutely. And I think too, it's about allowing the competency to take place where it needs to take place. There's so many where, again, we spray and pray it on everybody and it just doesn't work. And we're creating beautiful, mediocre organizations. I've never seen anybody yet put a banner in the lobby that says shooting for mediocrity. No, we're shooting for excellence. So your team that was doing great with our CAUTIs was striving for excellence and was achieving it. And now what do? Oh, who cares anymore? You've just dropped that engaged person down to mediocre. In your efforts to bring up the people below the line and bringing them up to the level of where they need to be for safety, we tend to not do well with those. I want to lift up our low performers and I want to lift up our high performers at the same time. And that takes a talent and that takes a different kind of system thinking. Leaders have to think in a different way. Educators and managers have to think in a different way.
Hmm. Absolutely. Oh,
Do I have an amen?
I
We'll go
was
with an
gonna say,
amen.
I'm like sitting here. They can't see me, but I'm shaking my head. Like you're preaching to the choir here for sure. I mean, there's nothing worse in any aspect of life than getting the email that says we have a problem. Everybody needs to fix this. Blah blah blah. And you're like, are they talking to me? Because I think I'm doing that right. But like, I mean, it makes you start to question sort of everything, sort of that, we're just going to put this blanket thing out there and make everybody do it because it's just easier to have everybody do it than to really focus on where the problems are.
And then you feel invisible. And why would you want to be in a place where you feel invisible? So that's where the engagement comes right back around. If you feel seen, if you feel like you belong somewhere, you're more likely to contribute to that. It's in that family of who we are. It's back to what Brene Brown talks about in almost every one of her books, is that belonging principle. So if we say when we look at competency or engagement and all that, you got to feel like you belong as part of a team, that when you say this hospital, this organization is mine, I influence it every day and I'm proud of it. That to me is the essence of engagement, not up above told me I've got to do this, this, and this. That's just an employee then. I don't want that.
Yeah. Well, and I think, I guess before this conversation, maybe I didn't understand the importance of it's not just, the what, but it's the how, and how we validate competence, how we approach people on, building their, professional identity or their professional practice. How we do that is even more important to growing engagement.
And actually, I think all day long, this is the I shouldn't say the humorous part of my job, but it entertains me every day. I go into organizations and we tell people two opposite messages all the time and in different categories. For example, we tell them, we want you to be a critical thinker, but yet we'll tell you what to do and how we're going to be checking you off. I think, well, that's kind of opposite. Or my favorite one is, it's all about the patient. It's patient-centered care. It's all about the patient. And then they'll say, oh my goodness, the surveyors are here today. Quickly, everyone over here. Well, I'm with a patient. Leave them, leave them. I mean, it's like, what do you want from me? And sometimes I think we are telling people two different things, or our words say one thing and our actions say another. So frankly, a lot of what I think is related to competency has to do with how we as leaders, formal or informal, that could be managers, educators, everybody, how we come together to understand exactly what you're talking about here. Do we know what we're actually trying to accomplish here? This isn't just completing a list and checking people off.
Yes, absolutely. So let's talk about that then. So let's say we're in an organization where we might be telling them two messages. Leaders, educators, they're trying to maybe take a different approach to competency. Where do you even begin? How do you begin to simplify this process? How do you begin to just look at this differently? What advice do you have?
Well, if anybody's ever cracked open any of my books, there's three words that seem to pop up all the time. They should for you: ownership, empowerment, and accountability. Those are the three words I keep. That's part of my model. Everything, it's always there. So I want to then look at what are our systems that allow people to own their care, their work, their service, and their competencies. So we have to look at that. And having the educator pick your competencies is not achieving that goal. They can help you facilitate that process, but not do it for you. How can we empower people where we have the employee at the center of the verification? And how can we empower them with choices and options so they have control over things? And then how can we create an accountability-based culture, which is really about what we say we're going to do, we do. So I usually have some discussion with leaders even. Are we expecting everybody in this organization to be competent? And people say, well, of course. Okay, then let's look at all of our actions to see if we really are doing, let's look at our own report card on that. And sometimes when you look at, here's a scary one, but I've seen managers who write a disciplinary note. I'll just use this one. A disciplinary note that says, I'm going to follow up in a month. What percentage of managers actually follow up at the end of that month? And most organizations, that's 20 to 25% of the time. So I'm not saying it all comes down to disciplinary action, but if we say this is important enough, do we get distracted by the next shiny thing and we never kind of go around to that? Or do we ask people what was important to you, or ask them, what kind of competency should we look at this year? And I like to give them forms and tools to be able to pull all these different pieces and then pull in the strategic plan and filter up to the surface the competencies. You can put ownership, empowerment, and accountability into everything you do if you just take a look at your systems. That's where I would start, right there.
I think another piece of, sort of that disengagement too is the flavor of the month mentality of, oh, well, we were working on Caudy last month. I haven't heard anything about it in a while. Is that something we're still doing? You begin to question when you do have that flavor of the month happening.
It just allows people to understand why we're doing what we're doing. When they are part of the selection of the process, and that's key to it, and they understand that, okay, we have a problem with this, or here's a new thing, and here's why we're doing it, then people are much more, I guess, committed to it. They say, we understand why. And they're part of the solution. Okay, so here's a story that really kind of exemplifies that. And this is a group up in Montana that was using my competency model for about 3 or 4 years. They sat down to select their competencies. It was the Shared Governance Council, the manager, and the educator all together in the cardiac area. And they were saying, okay, what's new, changing, high risk, and problematic. They were using a selection worksheet that I recommend. And so they saw that one of their problems they were having was with falls. They were having a lot of falls yet again this year, like last year and the year before. So somebody on the team says, oh, we're going to have to do the falls competency again. And so they said, okay, yeah, we have to do that. And then somebody said, why would we do it again? We did it last year and the year before. We all passed, and falls didn't get better. So why would we do it again? That's the definition of insanity. And they said, yeah. And they said, but you know what are we going to do? I mean, our falls are in the toilet. We got to do something. And someone said, well, let's just think a minute. I mean, we don't want our patients to fall. We put the red bracelets on them. We put the red socks on them. We put the thing over the bed that says falls precaution. We talk about it in huddle. Why is this still a problem? And then somebody said, well, when is it happening? Where is it happening? Who's involved? And they said, let's pull all of our QI data, our quality data, and look at all of the data and figure out what's really happening in our backyard. And they noticed they had 2 falls on one day, and somebody said, oh, I was working that shift. It was crazy and chaotic. And then somebody said, I was working on this day and we had a fall and it was crazy and chaotic. And then another person said, me too here. And they realized that every day they had a fall, they had, it felt like a crazy and chaotic day. And they said, could it be that falls is not the problem? Falls is a symptom of something else. Could it be that us being able to manage a crazy and chaotic day is actually the skill we're missing, not the knowledge on falls? And they said, well, maybe, but how would we even do that? I mean, when we make it a competency, what would we do with that? And so they said, well, who's good at de-escalating, craziness? And they said, well, maybe behavioral health can help us with de-escalating crazy. I don't know. They called over to behavioral health and they said, oh yeah, we got like 3 competencies we could show you. And behavior. The psych people helped the cardiac people come up with a competency on de-escalating craziness on your shift. And everybody on the cardiac unit that year did one of their 5 competencies that they selected was on de-escalating craziness in the day. Everyone had to show that they could do it. There were different ways they did the verification of that, very creative ways. And they did one of their 5 competencies for that. And what I love was that at the end of the year, after everybody did that, they dropped their falls by 68%.
That is incredible. And that is what we need, right? Because when I think about competency, it feels like it's so much easier to just say, falls is an issue. Let's do the falls competency again. Let's not think beyond that. Let's check the box and move on. And that is why it seems to me anyway, that is why we get stuck with continuing to not have the outcomes that we are trying to achieve because we keep doing the same things and it's clearly not working.
And then what I love is this group called me. I wasn't even there. They called me to say, Donna, we're so proud of ourselves. Here's what we did. And they said to me this, if we didn't own our competencies, if we didn't have the right to select our competencies based on data, they don't just get to pick anything they want. They said, we wouldn't have asked the second part of the question. They knew the data on falls was in the toilet. They knew that. But they said, what else is missing? And what was missing was their gut feeling of the day. There was more data than just what the quality department could give them. It was their own data to say, what did that shift feel like? What did that day feel like when we had the fall? And that was a second component of information that got to the real issue. And they made a difference in their patients. And they said to me, we made it safer here for our patients on this care area. And they were so proud of that. That's what we want. And it's not about that from up above that we're not going to, focus on falls. Of course, everyone's focused on falls. So if your data falls below or above where you need it to be, you got to do something about it. And we gave permission to the team to do something about it.
That is such a cool story. Thank you so much for sharing that. So much to learn, I think, about competency, about that ownership, about empowerment, about accountability from that story. So really cool. Okay, so looking ahead, I want to kind of switch roles here and think into the future a little bit. As our nursing workforce continues to evolve, as change probably continues at an even more rapid pace than it is already. How do you see competency evolving?
Very good question. I think it's back to creating competencies that really matter. I've seen some shifts in the way people are actually looking at competencies rather than, again, the procedures and tasks and how to operate a machine and things like that. I've seen people that are looking at a competency like during orientation, the ability to learn on the fly. Show me I'm not just going to tell you could look it up. I want you actually to prove to me, show to me 4 times that you can that you can show that you know something or don't know something, and you can go look it up. You can call somebody that, during when I'm precepting somebody, I might say, if they ask me, well, how do I do this? And I say, okay, would you like to use this as one of your learning on the fly competency verifications? Or do you want me to just tell you what to do here? And then the new employee can oh my God, I don't know if I'm ready yet. Okay, yeah, okay, I want to give it a try, And then you have to then show me what you don't know and where you would initiate your own education, look it up, because I want you to demonstrate to me that you can use our resources, you can access stuff, you know who to call. It's not about knowing everything. We all know that. The scariest professional on the planet is someone who says they know everything. That's not realistic. The best professional is someone who's always curious. I think I'll look it up again. What other outcomes could we have with this that might impact what's going to happen? All of that stuff. So that's an example of one, the ability to learn on the fly. I've done some other attitude competencies. I've done some things with some groups where we just finished one in an emergency room to distinguish between what's urgent and what's important. What you need to respond to right now and what's important that could be high risk, but you have time. So you can slow the roll. They called it the slow the roll competency, So you can distinguish, is this an urgent thing or is it an important thing? Because that makes a difference in how we respond and our purposefulness on deciding the actions we take. It's not about running the machine. It's a different way of thinking in the emergency department. So I think our competencies are going to look very different in the next 5 to 10 years.
I think they're going to need to, too. I think that we can't keep, checking lists and checking boxes in these silos, that we do really have to look at. And how are all of these, the bigger picture of all of this being applied? When you talk about that learning on the fly, to me, this seems like something that is just innate for me, that I'm always like, well, I don't know how to do that, but I can probably figure it out. It seems though, and I don't know if this is a generational thing, and this might be a tangent that we can cut later if we need to, but is this something that is missing in a lot of people, that they just expect that they should know it, or if they don't know it, they don't know it. Big deal.
Mm.
Do you see that missing?
Yeah, I will say I'm going on my 40th anniversary as a nurse here pretty soon. And I heard this back when I was a young person too. And I think sometimes we say could it be that's the people they changed? I think I've seen different groups where some do well with us and some don't. We've all probably experienced somewhere, well, someone say, didn't they teach you that in school? Are you going to be willing to ask more curiosity questions in the future when you get that kind of response? No, because that's your culture. I've also been a part of other cultures where the very experienced nurses would sit around and have some discussion amongst themselves, even during breaks or during report, and say things like, I'm just not getting the results I need from this situation or these interventions I've been using. Does anybody have some other ideas? And they reflected with each other. And I thought, this is a nurse of 30 plus years of experience and they're still not certain. That was such a good thing for me to see. So I think it's more about culture than it is about generation. I think, yes, there are differences with our generations. I get that. And I'm not wiping that out because there's different reasons we get motivated about things. But the connection, the passion we have for something, I think comes from the culture that allows this or that to happen within an organization.
No, I think that's what it is. Like I asked the question genuinely because I wasn't putting that connection to culture there, but I do think that's what it is. If you're in a culture that encourages that type of behavior and models that type of behavior, you're going to more likely develop those types of thinkers and those types of nurses.
Absolutely. And I rob from other industries blindly. I mean, just blatantly. I love it. So it's great. But in the airline industry, you'll see over the last decade or more, they changed how you'd hear people talk about the door from the cockpit to the back of the plane. There was a hierarchy there that they purposely tried to dismantle. And now when you go on a plane, you can hear things like the pilot saying, welcome aboard this plane today or our flight, blah, blah, blah. And we have an exceptional crew in the back. They give great respect to the crew versus before it wasn't. It was more, I'm the captain, do what you're told. And they said that affected the ability for that team to function together. So I think a lot of times we have to examine what culture are we in? Is that the culture we want? What components do we want to keep or change? It comes down to mostly culture. And it could be even culture within teams that are different from other teams in the same organization or even shifts sometimes too. So.
Well, Donna, I have learned so much from you today. I was so grateful for this conversation. We've talked about competency, what it is, why it matters, what it's influencing, where to start, even thinking about into the future how things will evolve. Before we go, though, I do have one last question, and I do ask this of pretty much every guest that comes on the podcast. But when you think about competency, and you think about the impact that competency has, what's one strategy that you see organizations using that you think makes the biggest difference and something you wish more organizations would adopt?
That's a very good question. I think just to have a reflective conversation to say, what do we like or not like about our current culture or process and put them into some categories. Because too many times organizations stay with the things they don't like just because it's familiar. So because they're comfortable there and they hate it, the checklist, let's get rid of them. But, oh, it's easy. I mean, we use that term several times during this podcast, because it's easy. Easy for what? To not get to our goal? That's not an excuse. So I think awareness is so good to say, what do we like about our process? Because you don't want to throw the baby out with the bathwater. But at the same time, let's not hold on to stuff we don't even like. And we've been whining about it for years. So to say, we want to move to something that holds this to be true and keep it there, but get rid of the stuff that does not serve us well. Simple things like that. I even say with every policy that you have in your organization, I always ask the question, you read a policy, does it serve you or does it control you? If it controls you, get rid of it. If it serves you, keep it. And that's where we go next, because that will shape the culture.
That is so great. I mean, thinking about, being brave enough to try something new.
And we don't have to change unless the change is warranted. I don't want to take people to someplace completely new where they don't feel comfortable. But again, being aware of what do you like and what you don't like. Everything in life is like that. You change a job, don't jump off to a new job without saying, I really like this part of my job. I want to keep that. Or you even said to me earlier today, you really loved working with people and developing people. You didn't even know that when you first started in your nursing profession, but you love that. So as you move on to other things, you want to keep that part that you love, but you might want to get rid of this or that. I like to work indoors or outdoors. I want to travel more. I don't want to travel as much or whatever it might be. You need to know the pros and cons of everything that go with it. So
Excellent. Well, thank you, Donna, so much again for this conversation today. I'm really glad that you were able to join us, and I know that our listeners will walk away with just as much, if not more, than I did.
thank you, Nicole. I appreciate it.
Wait, before you go, I want to make sure you know all about our suite of resources you can use to support your new graduate nurses. This includes our Academy, a coaching program designed for organizations as they prepare for the implementation and ongoing sustainability of a nurse residency program. Work one-on-one with residency program experts to make sure your organization is residency ready. Our Clinician Wellbeing course is an asynchronous online course that aims to enhance the well-being and resiliency of healthcare professionals, equipping them with the necessary psychological capital to navigate challenges inside and outside of work. Supporting Nurses is another asynchronous online course for preceptors, mentors, and coaches to learn the skills they need to support any new hire. Both of these offerings can be used as a standalone professional development opportunity or to augment any nurse residency program. And we can't forget about the program that started it all, the online nurse residency program. This includes a comprehensive curriculum designed to support new graduate nurses applying all the knowledge they learned in school to their practice. We focus on professional skills, personal well-being competencies, and new graduate nurses even get the opportunity to create real change in their own organization. Offered completely online and in a blended format, this program is highly adaptable to all clinical practice settings. You can learn more about all of these programs and more of what we offer using the links in the show notes below.